steroids in DME evaluation, DME management. So there are some recommendations by Retina where they advise the insufficient responders to anti-VEGF injection to consider steroid or a contraindication of in a major CV, cerebrovascular accident or cardiac event, and not willing for monthly injection. This is not actually true, but you should have the patient for initial few months for glaucoma evaluation and in pseudophakic patients. So these are some of the recommendations. Even in US, they recommended steroids when there is suboptimal response to anti-VEGF. Indian protocol said consider steroids in pseudophakic eyes that have plateaued or persistent DME needing cataract surgery, or when frequent follow-up is difficult, systemic contraindication, vitrectomized eye, extensive hard X-ray like that. So there are OCT biomarkers. Dr. Talwar has beautifully mentioned it in the initial talk, like large cystoid edema, hyperreflective dots, hyperreflective foci, intraretinal or subretinal, and this is pre and post steroid injection, how it is reducing. These are all biomarkers that we should look when we plan intravitreal steroid injections. Drill is a poor visual outcome, but sometimes steroids may work better than anti-VEGF. Submacular foveal detachment, it improves with both systemic, intravitreal steroids and anti-VEGF. So these are the indications when we consider steroids based on inflammatory biomarkers that I just mentioned, like lot of lipids, non-responsiveness to anti-VEGF, systemic contraindications, recent events, vitrectomized eye, DEX implant may be better, and difficult to come for a monthly follow-up because one injection lasts for 2 to 3 months. So these are some of my cases. Again, some colorful photos. This is a lot of hard X-rays. So we combine all these things, steroids, statins, laser in a post-CAD patient. And this is the treatment after a few years, the right eye before treatment and right eye after treatment. So it does well with these sort of biomarkers. Again, one more case, pre-treatment is put above and the post-treatment below. Some of the hard X-ray from the fovea may not go, visual improvement may not be very good, but there is beautiful response with steroids. And this is multiple anti-VEGF injections and laser, still it is not working. So that time we are given triamcinolone followed by cataract surgery. This is the difference in picture. So this is another one. Post laser, Ozurdex, and cataract surgery. Just the lower picture is the same as the above one. So that is post treatment. Dramatic changes are there. So IVTA with laser, pre-treatment and post-treatment. This is pre-treatment, and lower one is post-treatment. This is another one. Okay, laser with the triamcinolone, left eye and right eye. Sometimes the hard X-ray may not go in the fovea, resulting in suboptimal response. Then this is a forced phaco-vitrectomy for VMT followed by Ozurdex. These cases, post-vitrectomy Ozurdex works well because the other drugs may not be feasible. Problems with steroids is IOP and cataract at the expense of cost and less injections. So in conclusion, steroids are part of the armamentarium against DME, used based on OCT biomarkers. FFA is also useful here. When there is a contraindication for anti-VEGF, nowadays the nephrologists are also telling not to give anti-VEGF. So suppose such a patient comes, you can always think about DEX implants. In pseudophakia, and mainly NPDR only, PDR we don't give steroids, and in vitrectomized eyes. These are our current use of dexamethasone implant or steroids for DME. Thanks for the kind attention.
Thank you, sir, for the presentation. Now we are inviting Dr. Noemi Lois from United Kingdom. She'll be shedding light on the role of subthreshold laser in diabetic macular edema. Dr. Noemi, are you able to hear? Are we audible?
Yes, I hope that you are seeing the first slide.
Thank you. Thank you. Good morning.
Great. Good morning. And, well, good afternoon to you all. I understand.
Thank you.
And thank you very much for the invite. It's really nice to be here with you all. And thank you for to the previous speakers.
You can proceed with your presentation.
Yes. Can you hear me? Can you hear me? Can you hear me?
Yes, yes.
Okay, thank you very much. Sorry, I thought that you were not hearing. Okay, So I was asked to talk about diamonds, and this is what I'm going to do for the next few minutes. But before I start, I like to tell you a few things that you might find interesting, especially after hearing the previous talks. So in the UK, in the United Kingdom, we have the National Institute for Health and Care Excellence. We call it NICE. NICE is responsible, it's an entity from the government, and is responsible for reviewing any health treatments that come new to the system. And of course, they review the anti-VEGFs for the treatment of DMO in what we call single technology appraisals. And what they do is they review all the evidence that is there out in the literature and the evidence that is provided by the manufacturers of these drugs. And by the way, before I start, I want to say that I have no conflict of interest whatsoever to reveal today. So after the NICE reviewed these drugs, the advice from NICE was, and still remains, that if people have central involving DMO of more or equal than 400 microns in central retinal thickness, meaning in the center 1 millimeter, the treatment of choice should be anti-VEGFs. But if the center is less than 400 microns, laser treatment is recommended. And I can explain in detail because I didn't want to go into this on the interest of time, but I can explain to you all where they got the, of course, the evidence to give this recommendation. But this is what we should do if we follow NICE advice based on best available evidence. And this is centrally involving DMO in our clinics. And this is certainly what I do. Macular laser, as we just heard Dr. Mahesh explaining to us, is also, of course, a treatment of choice for people that have DMO that doesn't respond fully to treatment. And even randomized control trial data shows that might be 40 to 60% of people. And in clinical practice, in real life, it might be even higher, as we also heard. Macular laser is also a treatment of choice for people that have DMO and good vision. And I'm going to refer to this protocol B of the DRCR network a little bit later on. But that's why it was said. And of course, it's the treatment of choice, as again, Dr. Mahesh really nicely showed us, for treatment with no central involving clinically significant macular edema. Now, if we have the patients and we want to do the laser treatment, we need to choose from two options. One is to do standard laser, which indeed, as we heard, creates a little burn. But we have also Subthreshold micropulse laser. And the characteristic of this laser is that it's very short pulses, and the time in between is quite long. So it allows the tissue to cool down, and then we don't get a burn. And there's a lot of studies showing that it does not cause any structural damage, as determined with autofluorescence imaging, OCT, OCTA, but it has an effect. And even it doesn't cause any functional damage, and that was determined with microperimetry. There were a number of randomized controlled trials done, and those are listed here. But indeed, these trials had several issues with regards to the trial design. So sometimes people think that a randomized controlled trial is already evidence and you can take home that evidence, and that's not the case. It depends on how that randomized controlled trial is designed. But there was, of course, consensus with all these trials that Subthreshold micropulse laser appeared to be comparable or superior in efficacy than standard laser, but with less potential side effects. But there was a systematic review and meta-analysis which was undertaken on the auspices of the Cochrane collaboration. And Cochrane collaboration, I can tell you, is very strict on how these systematic reviews are done. Again, if you see systematic reviews published in the literature, be wary, because some of them are not done in a very well manner, and so the results might not be that reliable. So on this basis, we plan to do diamonds to evaluate the clinical effectiveness and cost effectiveness of Subthreshold micropulse laser when compared to standard laser for the treatment of patients with central involving DMO when the central retinal thickness was less than 400 microns, as per the advice of NICE. It was a pragmatic, investigator-led, so there's no commercially a company involved in this trial whatsoever, multi-center, allocation concealed, randomized, equivalence, double-mask clinical trial, which we undertook in 16 sites across the UK. So it would give a good flavor of what will happen if the results of the trial were to be implemented, because it was involving a good deal of the population of the UK in different areas. So the participants were, as I mentioned, people with central involving DMO with less than 400 microns central retinal thickness, and I'm showing you some examples of these patients. What did we do? Well, we randomized patients 1-to-1 to receive either a standard laser, done as per routine clinical practice. Most of the people follow the ETDRS, modified ETDRS guideline. And then for the Subthreshold micropulse laser, we used the 577A laser, the yellow laser. It was applied confluently. We had grids of 7x7, as I'm showing you here. We put 3 grids on top of the fovea, above the fovea, 500 micron away, 3 below, 1 in one side, 1 in the other side, and we would cover any other areas that had edema and macular thickening. We did do titration, and I think that this is very important, especially in eyes that are well pigmented. And what was the titration? What it means is that we will start with the standard laser in an area of edema, a single spot, and we will test with the minimal power, which is 50 microvolts, whether we saw any take whatsoever. If we saw any take whatsoever, that would be the threshold. And then what we would do is we would multiply by 4. So it would be 200, and then we would apply the laser in the micropulse mode using these grids with that 200 millivolt. That's what we did for all the patients. The primary outcome of Diamonds was the mean change in best corrected distance visual acuity in the study eye from baseline to month 24. Vision is what matters to people with DMO. And I would like to stress that Diamonds was designed with a group of people with diabetes and DMO, what we call the Patient and Public Involvement Group, the PPI group. And they, of course, for them, vision was the most important outcome. Then we had other secondary outcomes, including binocular vision, because of course it is that we go around with both eyes, not just one eye in our daily living. We have central subfield thickness, we have the mean deviation of the Humphrey 10-2 visual field to test for small potential visual field defects that could develop as a result of the laser around the center. Proportion of people meeting driving standards. This outcome came directly from the Patient and Public Involvement Group. They told us, this is what matters to us, maintaining our ability to drive. So we included it in the trial. It didn't come from the investigators. We have several measures of health-related and visual-related quality of life. We look at gain, side effects, number of laser treatments done, and use of additional treatments like rescue treatment, including anti-VEGFs. Diamonds was powered for equivalence. That means that we needed to have more participants than trials testing just in non-inferiority or superiority would. So we have also power to the test then in non-inferiority and superiority in Diamonds. The trial was not powered only, as most of the trials are powered on the primary outcome. We power it also on important secondary outcomes. And as an equivalence margin, we use 5 ETDRS letters because the evidence suggests that 5 ETDRS letters is not a change that is clinically meaningful to people and certainly can be red test variability, as we all know. So we estimated that we needed to have 266 participants in Diamonds, 113 in each arm. And as you can see, even by month 24, so at the end of the trial, when the primary outcome was measured, we had more than 113 in each arm. So we have good power to answer the question we put forward. There were no differences, not important differences in baseline characteristics among the two groups. And in general, our population with DMO in the UK, as you can see, are overweight, obese, or morbidly obese. The HbA1cs are high, 8.5% here in the UK. And as you can see, people had slightly reduced vision when they entered into the trial. I'm putting here the comparison of patients in the Diamonds trial compared to the Protocol B, because I usually am asked about this. Oh, Protocol B showed that it's the same, doing observation or doing laser in people early on. And again, a word of caution. So these trials are very different. As you can see, in Diamonds, we have higher HbA1cs, we have reduced vision, which, as you can see, less than 20/30. That would be 6/18 injured Snellen, I believe. So we had a third of patients, whereas there was none. So most of the people in the DRCR network of Protocol B had very good vision, had thinner retinas. The most important thing I want to point out to you is that there were 3 arms in Protocol B: treatment with anti-VEGFs, i.e. aflibercept, or macular laser, or observation. And in a trial, for the investigators to be able to randomize the patients to one or another arm, we have to have equipoise. What does equipoise mean? It means that I, as treating ophthalmologist, I have to feel confident that the patient is going to do equally well in each of these arms. Otherwise, ethically, I couldn't randomize the patients to observation. And this is a major thing because, of course, the patients that went into Protocol B, the investigator felt that they would be doing very well or equally well with observation. So no surprise that they found that observation did as well as the other treatments. So what did we find in diamonds? We found that the Subthreshold micropulse laser was indeed equivalent to standard laser on the primary outcome, the change in visual acuity from baseline to month 24. These are an example of 2 patients doing equally well, doing very well at month 24, just for illustration. And we saw no statistical significant differences in any of the secondary outcomes that I mentioned to you, with the exception of a slightly increased number of treatments in the Subthreshold micropulse laser arm. But whether it's clinically important or not is a matter of debate, because it was only half a session in the 2-year period of the trial. So what else I want to tell you about diamonds? Well, the mean number of laser treatments during the 24 months was 2.4, so less than 3 in the Subthreshold micropulse laser arm, and less than 2 in the standard laser arm. By the way, patients came every 3 to 4 months to our clinics, so not very often. So most of the participants, that's the, and that's what I'm mentioning it, fulfill driving standards, because this is the outcome that was most important to participants besides vision. Indeed, 9% of participants dropped more or equal than 10 letters. At that time, we didn't actually check whether this 10-letter drop would be reversible, which is very important. Now, we are conducting another trial that we can discuss later, and I'm going to be looking at what is the reason for sight loss, because a lot of these patients may have recovery vision. But just to give you a perspective, in the aflibercept arm of the Protocol B, which I just mentioned, exactly 9% of participants dropped more or equal than 10 letters by month 24. 18% in the Subthreshold micropulse laser arm and 21% in the standard laser arm receive rescue treatment with anti-VEGFs. But the total costs, and the total cost meaning the full care, I'm not referring just to the laser treatment, it's referring to the full care, all the visits during the 2 years, was less than £900 in the Subthreshold micropulse laser arm, and a little bit over 1,000 in the standard laser arm. So in conclusion, Subthreshold micropulse laser is equivalent to standard laser for the treatment of central involving DMO, less than 400 micron central subfield thickness. I hope I showed you that this treatment is very much here, certainly in the UK is very much here, and it should be, because as I showed you, it's effective and it's inexpensive. And from the perspective of the patients, it's much easier to go through it. And again, we are looking into this in great detail in a new trial that we are about to start called Oedema. And I believe that the patients have the right to have this treatment offered at least to them. And with that, I'd like to thank the multiple investigators, of course, that were part of Diamonds, the trial steering committee, the data monitoring committee. Iridex provided the lasers in a loan-free mode, but they had no involvement whatsoever in the trial. As I mentioned, this was not a commercial trial. This is an investigator-led trial. And of course, I have to thank the patient and public involvement group, which I mentioned to you, and all the trial participants, because without them, we wouldn't be able to get any evidence for any of the treatments that we use. And I'd like to thank you very much for your attention.
Thank you, Dr. Noemi. Now we'd like to, we have a question.
Dr. Noemi, thanks a lot. This is Dr. Giridhar. I would like to ask you one or two questions. One is, how long do you wait after one cycle of micropulse for you to decide that this is not enough and you're giving the second cycle of treatment?
Thank you very much. That's a really excellent question. So in Diamonds, we did the treatments every 3 to 4 months. So if you ask me now, and again, I have organized now DAME, which is going to be a very large trial too. And in that trial, I'm advising that we can do the treatment every 2 months if needed. And we can do the treatment, and I've been doing it, even complementing anti-VEGFs. And that's the new trial that's the aim about, the complementation. But I would be doing it even when the retina is dry or nearly dry to maintain the effect. Because as you know, in a lot of people, of course, when they have had anti-VEGFs, as soon as you stop them, the edema comes right away back. So my advice is every 2 to 3 months, and certainly treat if you see any type of fluid present, and not just observing.
And second question is, what's the pattern of treatment? I mean, that is, how do you treat? I mean, you told about the duty cycle and also the power, but what's the pattern of treatment? I mean, you cover how much of area?
So I use those grids that I showed you. So those grids are 500 microns from the center of the fovea. As you probably know, even if you cover the fovea, this laser will not cause damage, and that has been shown too. And that's a great advantage because people are no longer worried about burning the fovea. But we would treat all the area of edema. I think that this is very important. So it depends on your patients. I saw some of the examples given, and of course, some people have extensive edema, then we'll have to cover all that area of edema. But the minimal treatment that was given to all these patients was the treatment that I showed.
Okay, thank you.
There's another way of titrating the power. You increase the micropulse power to high power till you get a faint burn. Then you can use half of that. That is not the ordinary thing. Micropulse power. Micropulse laser power, increase the power to higher power and get a faint burn. Then reduce it to half. That way also some people, do you do that or only?
I understand. So now, to be honest with you, we use the protocol that the Iridex, manufacturers advised. And now having the information and the robust data from Diamonds, I would not change that. I know that what we did worked. I think setting the threshold, as I say, is very important. And I think that I stick to the protocol now because I know that it works based on best available evidence.
Then usually I've been using micropulse for 5-6 years. I treat the microaneurysms with the ordinary laser. Then the thickening area using micropulse. So this also works. I don't have a randomized control trial. This is from personal experience. I don't think many people are having micropulse laser in this part of the country.
Okay, well, I think that what you're doing with laser is essential. And I think that what basically Diamonds is telling you, even if you cannot do subthreshold micropulse laser, is that you can reduce a lot the power that you use in your standard laser to nearly see nothing. And I agree with you that, of course, if you have a very leaky microaneurysm and you treat it, you might get rid of it. And you show us beautiful examples of this. What I'm trying to pass the message is that do not think that macular laser is not a good treatment for people with DMO. And remember that there's a lot of commercial interest behind anti-VEGFs. And we have heard how we get 5 to 8 letters of improvement after treatment in real world practice. So that is nothing. That is not a clinically significant change. So I think that we have to be very, very careful with interpreting the literature. And then I know there's discussion after, so I don't want to say more things. But also the trials that compare standard laser with anti-VEGFs had included extremely thickened retinas. And there's now a Cochrane review, and so you can see how thickened these retinas were. So these patients were certainly the worst possible patients that you could put for laser.
Absolutely agree with you. I am a big fan of laser. That's why.
Thank you very much.
Thank you. We'll proceed to the next talk of the session. I invite Dr. Juhi Cherian, our consultant, to talk to us about impact of wide field imaging, clinical assessment and management of diabetic retinopathy.